Hello. Elbow dislocation. First, we want to talk about the epidemiology of elbow dislocation. It accounts for 11% to 28% of injuries of the elbow. Posterior dislocation is most common. Simple dislocation are those without fracture, while complex dislocations are those that occur with an associated fracture and represent just under 50% of all elbow dislocation. Highest incidence is 10 to 20 years old age group associated with sport injuries, although recurrent dislocation is uncommon. The anatomy of elbow dislocation. The elbow is a modified hinged joint with a high degree of intrinsic stability owing to joint congruity, opposing tension of triceps and flexors, and ligamentous constraints. The three separate articulations are ulnohumeral, which form the hinge, radiohumeral for rotation, proximal radioulnar also for rotation. The stability. Anteroposterior stability through the trochleo-olecranon fossa, chronoid fossa, radiocapitellar joint, biceps, triceps, brachialis muscles, and this during flexion. For valgus stability, it's medial collateral ligament complex. The anterior bundle is the primary stabilizer in flexion and extension for medial collateral ligament, and the anterior capsule and the radiocapitellar joint function in extension. When in extension, it's not the ligament, it's bony from radiocapitellar joint. For varus stability, the lateral ulnar collateral ligament is static and the anconeus muscle is dynamic. Now we want to talk about the function of the medial collateral ligament. It is the primary medial stabilizer, especially the anterior bands. Full extension provides 30% of valgus stability. 90 degree of flexion provides more than 50% of valgus stability. Resection of anterior band will cause gross instability except in extension. So medial collateral ligament is very important during flexion. Lateral ligament. These prevent posterior subluxation and rotation of the ulna away from the humerus with the forearm supinated. Normal range of motion is 0 to 150 degree flexion, 85 degree supination, and 80 degree of pronation. The functional range of motion requires 30 to 130 degree flexion, 50 degree supination, and 50 degree pronation. Mechanism of injury. Most commonly injury is caused by a fall onto outstretched hand or elbow, resulting in a levering force to unlock the olecranon from trochlea, combined with translation of the articular surface to produce the dislocation. Posterior dislocation, this is a combined of elbow hyperextension, valgus stress, arm abduction, and forearm supination. Anterior dislocation is a direct force distracts the posterior forearm with the elbow in a flexion position. Most elbow dislocation and fracture dislocation result in injury to all the capsuloligamentus stabilizers of the elbow joint. The expectation include fracture dislocation of the olecranon and injuries with fracture of the chronoid involving nearly the entire chronoid process. The capsuloligamentus injury progress from lateral to medial. The elbow can completely dislocate with the anterior bands of the MCL remaining intact. So the capsuloligamentus injury progress from lateral to medial, and the elbow can completely dislocate with the anterior band of the MCL remaining intact. There is a variable degree of injury to the common flexor and extensor musculatures. Okay, for clinical evaluation, patients typically gird the injury upper extremity would show variable gross instability and swelling. A careful neurovascular examination is essential and should be performed before radiograph or manipulation. And again, you have to examine the neurology for the median nerve here by seeing the force of the thumb with the little finger, also abduction and adduction for the ulnar nerve, or abduction for the ulnar nerve, and for the radial nerve it's extension of the thumb, and nerve sensation, you know it. Following manipulation, serial neurovascular examination, okay. Angiography may be necessary to evaluate vascular compromise. Following reduction, if arterial flow is not re-stabilized and the hand remains poorly perfused, the patient should be prepared for arterial reconstruction with saphenous vein grafting. Angiography should be performed in the operating room and should never delay operative intervention when vascular compromise is present. The radial bus may be present with brachial artery compromise as a result of the collateral circulation. Here, associated injuries. Associated fracture most often involve the radial head and/or chronoid process of the ulna. Acute neurovascular injuries are uncommon. The ulnar nerve and anterior interosseous branches of the medial nerve are most commonly involved. The brachial artery may be injured, particularly with an open dislocation. Radiographic evaluation, standard anteroposterior and lateral radiograph of the elbow should be obtained. Radiograph should be scrutinized for associated fracture about the elbow. Classification. Here we have the classification. It's called descriptive. Simple versus complex, and complex, which is associated with fracture. According to the direction of displacement of the ulna relative to the humerus, we are also classify it as posterior, posterolateral, posteromedial, lateral, medial, and anterior. Treatment principles. Restoration of the inherent bony stability of the elbow is the goal. Restoration of the retroclear notch of the ulna, particularly the chronoid process, are also the goal. Radiocapitellar contact is very important. Radiocapitellar contact is very important to the stability of the injured elbow. The lateral collateral ligament is more important than the medial collateral ligament in the setting of the most cases of traumatic elbow instability. The trochlear notch, which is chronoid and olecranon, so trochlear notch is the olecranon and trochlea, and the chronoid. The trochlear notch, radial head, lateral collateral ligament should be repaired or reconstructed, but the medial collateral ligament rarely needs to be repaired. If the elbow is stable or can be made stable with surgery on the lateral side, the medial collateral ligament will heal properly with active motion, and its repair will not be necessary for stability. Mori recommend that our elbow should not re-dislocate before reaching 45 degrees of flexion from a fully flexed position. Jobiter and Ring recommended that the elbow should be able to go to 30 degrees before substantial subluxation or dislocation. Radial head fractures make up to 5% to 11% of cases. Medial or lateral epicondyle fractures maybe 12 to 34%. They may result in mechanical block following close reduction owing to entrapment or fragment. Chronoid process fractures occurred 5 to 10%. These are secondary to avulsion by brachial muscle and are most common with posterior dislocation, and have three types of fractures. Type 1, avulsion of the tip of the chronoid process. Type 2, single or comminute fragment including 50% of the chronoid process or less, and type 3, when the fragment is more than 50%. Elbow dislocation that are associated with one or more intra-articular fracture at a greater risk of recurrence or chronic instability. In this one, there is double fracture, fracture of the crinoid and also fracture of the radial head. Fracture dislocation of the elbow usually occur in one of several distinct, recognizable injury patterns include posterior dislocation with fracture of the radial head, posterior dislocation with fracture of the radial head and crinoid process, and so-called the triple triad injury. Like this one, fracture crinoid, fracture elbow, and dislocation. Triple triad injury. Varus posteromedial rotational instability pattern injury, anterior olecranon fracture dislocation, like this one, posterior olecranon fracture dislocation. And this is the varus posteromedial rotational instability. Okay. The following observation may be useful in guideline treatment. Triple triad fracture nearly always have a small transverse fracture of the tip of the crinoid, including the anterior capsular attachment. Much less commonly, the crinoid fracture is either very large or involve the anteromedial facet of the crinoid process. Varus posteromedial rotational instability pattern injury are defined by fracture of the anteromedial facet of the crinoid process. In the setting of the olecranon fracture dislocation, the crinoid fracture can be one simple large fragment, and it can be fragmented into two or three large pieces. Types of elbow instability. Posterolateral rotatory instability, which elbow dislocation with or without associated fracture. Varus posteromedial rotational instability, which have anteromedial crinoid facet fractures. And last thing, olecranon fracture dislocation. Okay, let's talk about the posterolateral rotatory instability. This results in dislocation of the elbow with or without fracture of the radial head and crinoids. This occurs during a fall on outstretched arm that creates a valgus, axial, and posterolateral rotatory force. The ulna and the forearm supinate away from the humerus and dislocate posteriorly. This may result in injury of the radial head or crinoids. The soft tissue injury proceeds from lateral to medial, with the anterior band of the MCL being at the last structure injured. It is possible to dislocate the elbow with the anterior band of the MCL remaining intact. Varus posteromedial rotational instability. This occurs with the fall onto the outstretched arm that creates a varus stress, axial load, and posteromedial rotational force of the elbow. This results in fracture of anteromedial facet of the crinoid process and injury to lateral collateral ligament, fracture of the olecranon, additional fracture of the crinoid at its base. The anterior olecranon fracture dislocation. This is result from direct elbow to flexed, direct blow to flexed elbow. Some authors suggest that this injury may result from some mechanics. The same mechanics would create the elbow dislocation. Okay, now I want to talk about the instability scale, which described by Mori. Type 1, posterolateral rotatory instability, which have positive pivot shift test, lateral ulnar collateral ligament disruption. Type 2 will have varus instability, lateral atriocollateral ligament, plus anterior and posterior capsule disruption. Type 3A will have posterior dislocation, valgus instability, lateral ulnar collateral ligament injury, anterior posterior capsule, and we will add posterior MCL disrupted. And in type 3B are the same with anterior and posterior MCL disrupted. This is 3B. Now we're going to the treatment. Acute simple elbow dislocation should undergo closed reduction with the patient under sedation and adequate analgesia. Alternatively, general or regional anesthesia may be used. Correction of the medial or lateral displacement followed by longitudinal traction and flexion is usually successful for posterior dislocation. For posterior dislocations, reduction should be performed with the elbow flexed while providing distal tractions. Neurovascular status should be reassessed, followed by evaluation of stable range of elbow motion. Post-reduction radiographs are essential. Post-reduction management should consist of posterior splint at 90 degree and elevation. Early gentle active range of elbow motion is associated with better long-term results. Prolonged immobilization is associated with unsatisfactory results and greater flexion contracture. Hinged elbow brace, like this one, through a stable arc of motion may be indicated in case of instability without associated fracture. Recovery, this is another type of the hinged elbow brace. Recovery of motion and strength may require up to 3 to 6 months. The operative choice. When the elbow cannot be held in a concentrically reduced position, radial use redislocates before post-reduction radiography or dislocates later on in spite of splint immobilization. The dislocation is deemed unstable and operative treatment is required. There are 3 general approaches to this problem. First, open reduction and repair of soft tissue back to the distal humerus. Second, hinged external fixation. And third, cross-pinning of the joint. It's first, second, third. Okay. Now let's talk about elbow fracture dislocations. This is a reasonable non-operative treatment. It is a reasonable treatment option in patients with dislocation and fracture of the radial head only. Patients who elect non-operative treatment need to be aware of the potential for instability and the substantial potential for restriction of motion or arthrosis from the radial head fracture. Under close supervision, it is reasonable to remove the splint and to begin active motion at the patient's first visit to the office, typically about a week after entry. Operative treatment. This includes radial head resection, repair or replacement, and lateral collateral ligament repair. This is the radial head resection, radial head repair, and radial head replacement, and this is the lateral collateral ligament repair. If the radial head cannot be repaired, resection and replacement with a metal prosthesis will enhance immediate and long-term stability. Most others do not support acute collateral ligament reconstruction. Some others, however, stress the importance of lateral collateral ligament to elbow stability and advocate reattachment of this ligament to the lateral epicondyle. Okay, we have here a case study about the lateral collateral repair. The following case illustrates an obese patient who suffered such an injury. The elbow was severely unstable while the weight of the arm was contributing to instability as well. During the surgery, the following inside to outside algorithm for fixation is used. So you have to start from inside to outside. Fixation begins with the deep structure and we move superficially through a lateral approach. The sequence is the following. First, assessment of the chronoid fracture. If large fragment, then fixation with suture or with a screw is indicated. Second, radial head replacement. And third, primary repair of the lateral collateral ligament complex using bone tunnel at the humerus and no anchors. We avoid use of anchors that increase the risk of infection. If the elbow is stable after following the above 3 steps, then repair of the medial collateral ligament complex is not indicated. In the case of the medial collateral ligament was ruptured as well. However, the elbow was stable after the completion of the three steps. Okay. If the elbow is unstable after completion of the above three steps, then the medial collateral ligament is repaired. If still unstable, then a static external fixator is applied for 6 weeks. Key points for success of treatment are: first, avoidance of overstuffing of the joint by undersize the bruces radial heads. Second, stable fixation of the lateral collateral ligament in the acute setting with a Krakow suturing method. A common mistake is the use of a large radial bruces head for better stability. Large head increase the chance of subluxation, pain, and stiffness. Krakow suturing method, this one. For triple triad fracture, we just finish it. Complications: loss of the motion. This is associated with prolonged embolization. Some other recommend posterior splint embolization for 3 to 4 weeks, although recent trends have been to begin early range of elbow motions after 1 week. Neurologic compromise: sustained neurologic deficit at the time of injury should be observed. Spontaneous recovery usually occur. Decline in nerve function, and especially after manipulation, and severe pain in nerve distribution are indicated for exploration and decompression. Exploration is recommended if no recovery is seen after 3 months following electromyography. Next, the vascular injury. The brachial artery is most commonly disrupted during the injury. Prompt recognition of vascular injury is essential with closed reduction to re-establish perfusion. If after reduction perfusion is not re-established, angiography is indicated to identify the lesion, with arterial reconstruction when indicated. Third, compartment syndrome. This may result from massive swelling during soft tissue injury. Post-reduction care must include elevation and avoidance of hyperflexion of the elbow. Serial neurovascular examination and compartment pressure monitoring may be necessary, with forearm fasciotomy when indicated, like this one, fasciotomy. What are the predictors of the compartment syndrome? First, you should have a great force injury. Second, with a big swelling, Second, a pain out of proportion to the movement, inability to flex, extend the arm, the fingers, and the wrists. And lastly, to measure the compartment pressure, which is more than 30 mmHg. Okay. This is the fasciotomy. Other complications are instability or dislocation. This is a rare after isolated traumatic posterior elbow dislocation. This is increased in the presence of an associated chronoid process and radial head fracture. It may necessitate capsulo-ligamentous reconstruction, internal fixation, prosthetic replacement of the radial head, or hinged external fixation. Last thing on the complication is myositis ossificans, which anteriorly it formed between the brachialis muscle and the capsule. Posteriorly, it may be from medial or laterally between the triceps and the capsule. The risk is increased with multiple reduction attempts, greater degree of soft tissue trauma, or the presence of associated fractures. And one last point in the athletic patients. It may result in significant loss of function, forcible manipulation or passive stretching, increased soft tissue trauma, and should be avoided. Indomethacin or local radiation therapy is recommended for prophylaxis after surgery and in the presence of significant soft tissue injury or associated fractures. That's it. Thank you.